All right, Camila, go ahead. So we're all set to go.
Thank you, everyone. It's a pleasure to have you here with us. We'll start this presentation now. The purpose of this presentation is to explore reaching the last mile in fragile settings with the supply chain, which we know in many of these challenging settings, facing multiple co-occurring disasters, it can be very challenging, and supply chain is sort of the backbone of the health system. There's no program with no supply chain, no product, no program. And so we know this is quite challenging. And on the Momentum Integrated Health Resilience Project, we did a bit of analysis on the project to learn from 7 countries. And we developed some material that my colleague Marie-Etienne will present to you. And then we will have a short presentation from 3 of the countries that had very interesting experiences over the last several years. This will be Niger, Mali, and Sudan. And once they are done presenting their experiences, we will hold the questions to the end and hope to have a discussion with you. Feel free to share your questions in writing or wait till the end to unmute and ask by speaking. You can raise your hand at that point. Make sure you're in the appropriate channel for the language, which you can see at the bottom of the screen and the team just explained. And yeah, it's a pleasure to have you with us. So I'll pass it to Marie.
All right, thanks, Nadia. Good morning, good afternoon, good evening, everyone. I'm Marie-Etienne. I'm a senior technical advisor at JSI and provide supply chain technical assistance in addition to other things that on the project or at JSI. So just to jump in quickly, because we want to have a lot of time for the Q&A at the end. So as Nadia mentioned, last year we collected information through desk-based interviews and questionnaires from 7 MIHR partner countries: Burkina Faso, the Democratic Republic of the Congo, Mali, Niger, South Sudan, Sudan, and Tanzania. And we also reviewed a few available reports to gain additional insight to better understand the challenges healthcare workers face to obtain commodities in fragile and humanitarian contexts. It was also to gain more insight into how commodities are dispensed and tracked and the bottlenecks to their availability. This was also to raise awareness around the importance of including the last mile as part of supply chain strengthening initiatives and to add to the body of knowledge about managing supply chain in fragile settings to make them more resilient. So out of this work, a set of useful practical resources were produced based from the findings. And I'll just quickly go over them. Next slide, please. Okay, so yeah, so these were basically the objectives. I won't go over them, but again, it's just to identify some challenges, what the bottlenecks were, better understand if there are any policy barriers, and also to formulate some recommendations based on the findings. Next slide, please. So out of the interviews and the desk-based review, three documents were produced. First, a summary of the challenges around commodity availability and how health workers and local governments manage are summarized in this report. And the findings are grouped into 6 supply chain functions: commodity availability, human resources, infrastructure, funding, transport data, and logistics management information system, security, and emergency procedures, preparedness, and solutions. And then the second document, the second resources is a recommendations document that includes suggested recommendations and documents to implement activities, initiatives, and suggestions to strengthen the supply chain. The recommendations are grouped into 7 categories: supply chain skills, preparedness, data, standardization, distribution, storage, and leadership. And the last resource is a template to develop a RMNCH commodity security strategy with attention on the last mile. And it's based off of the Reproductive Health Commodity Security Framework. And the importance of this is We believe that a strategy can be a good starting point to bring attention to priority areas, developing activities to address challenges, and to identify resources to implement the activities. The template includes sample objectives, strategies, and activities for each component, and includes links to practical resources including supply chain indicators, country strategies, emergency preparedness, and many more resources. And so you can find, there's a link in where you can find it, and I think maybe someone can post it in the chat, where you can find these resources. But in today's webinar, we'll hear from our panelists on the supply chain challenges they face, activities they've implemented to strengthen the supply chain and commodity availability, and a few lessons learned. So I would like to introduce the first panelist. To begin, I have the pleasure of introducing Dr. Hamza Toure. He is a supply chain management, child health, and immunization advisor in Mali and has over 7 years humanitarian experience in supply chain support and immunization. He joined MIHR Mali in October 2023. Before joining MIHR, the MIHR team, he worked for Médecins Sans Frontières, the Red Cross, and additional organizations in various countries with fragile contexts facing conflicts, including Mali, Burkina Faso, Central African Republic, Sudan, and Chad, where he worked with emergency teams, including tackling supply chain challenges to ensure last mile availability and to guarantee the permanent supply of medicines and vaccines at all levels. So, Hamza, please, the floor is yours.
Merci beaucoup, Marie. Moi, je
Thank
ferai
you
ma
very much,
présentation
Marie. I'm
en
gonna make my
français.
presentation
La
in French.
présentation concerne les zones
So
d'intervention du
we're
Mali
going
qui
to
sont
focus
confrontées à des
on the
défis sécuritaires
different
économiques et
challenges in
bien
security and in
entendu
the
la zone de
context of the armed
conflit ou normalité
conflict,
épargnée par ces conflits.
understanding
Ainsi, nous pouvons voir
the supply chain. The supply chain was highly impacted and with several challenges faced with myriad problems in supply. There is a single road or connectivity that connects us to the capital, making it difficult, not only with the dire or terrible state of the roads, but also some of the storage problems. We have huge qualified personnel issues, lack of personnel and skill sets, healthcare centers that have difficulties, and so we have road infrastructure problems, skill sets problems, security problems, and also regional supply problems. Another challenge to add is the lack of storage facilities. To have proper storage, cold chain issues, and from this data we can make a proper assessment or scoping. For many years, data have been insufficient and minimal because of the difficulty of gathering and properly report and gather data. Another issue. From 2023, we were able to identify and take into account these details of the supply chain with a joint work with the Ministry of Health. Next slide, please.
Ici, nous
All
parlons des
right.
interventions et
In a
activités
nutshell, we're talking about different key activities carried out by MIR. The first activity that MIR carried out was the situation and analysis of the supply chain, to have a proper baseline and diagnosis, to understand where we have to improve, bottlenecks, where we should focus and prioritize our efforts. After the situational analysis, we identified different activities, and we were able we trained 37 warehouse managers and in LMIS and stock management, understanding the logistics cycle of improving performance, but also guaranteeing better quality of data. and information that will be able to do the national
Nous avons aussi
assessment
eu à faire la configuration
to
de
better
13 centres de
understand
santé
these zones. We
communautaires
also had to configure
paramétrés à
13
multi-priorité
community
poste de
health
santé, et
centers,
cela
which were
a pu
not
être possible
included in the
grâce à la
Obstante
collaboration de
tool.
Mir
This was
Mali avec
possible
un autre
thanks to the
programme de l'USAID
collaboration
piloté par
of Mir
Kenya
Mali
aussi.
with yet another
Nous
program
avons aussi
from USAID.
identifié une opportunité de
We also
collaboration avec le Fonds
identified
mondial à
opportunities for
travers une
collaboration
recette
with
pour le financement des
with the
réunions
Global
des
Fund
comités techniques
for the
régionaux de
funding
coordination du suivi
for
et
the
de gestion des
co-financing
médicaments
of regional
essentiels et autres
meetings
produits
for
de
tracking
santé
of
qui
essential
sont des comités
medications
dont
and
nous
other
avons
key
appuyé leur
health
mise en place
products.
et cette
These are
collaboration
committees
a
and work
permis non
groups where we
seulement de
could
renforcer la
implement this
synergie, mais aussi de
collaboration. With this
combler les gaps
collaboration, we not only
financiers
can
pour la
reinforce
tenue des réunions de ces comités.
the process, but
Next
also
slide.
help to collect better data. Next slide.
Next slide, please.
All right.
Comme je vous le disais
As
précédemment,
I
nous
was
avions mené une analyse
saying,
situationnelle de la chaîne
we
d'approvisionnement
carried out
et
a
un
thorough
examen de certains constats.
situational analysis of
Ainsi,
the
en
supply
termes de
chain,
points
and
à
we saw
améliorer, nous avons
certain
vu qu'il
important
y avait
things.
une absence
We
de
had to
coordination
improve.
des acteurs de la chaîne d'approvisionnement
There was
au niveau régional et
lack of
local,
coordination
faible
of the
niveau de
players
disponibilité des
and the
produits
actors
contraceptifs
regionally and locally.
au niveau
Low,
des centres de
very low
santé où nous intervenons,
availability
le faible taux de rapportage de moyenne dans
of
l'hospice santé de janvier à
medication
septembre, où la moyenne était de
and pills.
45% en gao et de
Uh,
15% en
for
octobre.
the average was
L'analyse situationnelle a
47%
identifié
in Gao
l'insuffisance
and
de personnel
15% in
qualifié sur
Timbuktu of
la chaîne
inventory.
d'approvisionnement comme
So we
outil de
needed better
détournement dans ces zones.
personnel in
À contexte donné,
better
comme
trained
action à
personnel in
long
the
terme
supply
identifiée à la
chain
suite de cette
to
analyse
be able to cope
situationnelle
with some of the bottlenecks.
sont entre autres
Uh,
le renforcement
we
des
also were able
compétences
to
des gérants
identify
de dépôts de
the
vente et
need
les
to
DDC sur la
strengthen
gestion de
skill
stocks et
sets of
receipts,
those that
l'intégration des
managed
indicateurs du
inventories and
SIG,
storage
la chaîne
facilities and
d'approvisionnement
stocks.
dans la revue trimestrielle des
Um,
données que nous appuyons,
and
la mise en place
also
des
in the
comités de
quarterly
coordination au
data
niveau régional
review
et
and
district et
setting in
l'amélioration
motion
du niveau de
committees and
stock
district committees to
contraceptif
improve
dans
the
les centres
level
où nous intervenons.
and the quality
La
of
mission a eu
storage
à faire
for
des actions à long terme directement sur le terrain,
family
qui avait
planning
pour but de faciliter la
fields.
mise en œuvre de
And
certaines actions
we
à
had
long
the
terme,
objective
notamment
of
l'initiation du projet de
facilitate
décision
certain
avec les
this
directions
better
régionales
decision
sur la mise en
making
place des
with
comités dont le besoin
better
était un besoin
implementation of
crucial pour nous.
committees and activities
Next slide.
to know what are the needs, knowing what are the
En
real
termes de
needs. Next
résultats,
slide.
comme identifié lors
About the
de l'analyse
results that
situationnelle,
were
il y avait un
identified
problème de
during the analysis
disponibilité
of this
des produits
situation.
contraceptifs dont il faut
There was
améliorer.
a
C'est ainsi
big
que nous
problem of
avions
lack of
assuré la
availability,
dotation de 36 espoirs
and we were
où
able to
nous intervenons.
guarantee
Au total,
availability of 38,
2859
improve
dépôts,
availability
dont
in
1000 ont
38
été
zones
distribués,
with
dont
1,357 in the
1357 à Gao et
long
1509
term,
à Tombouctou. Pour les
1,357 in Gao,
métroples, nous avons
1,502
disponibilisé
in Timbuktu. For all the
6567
short or long term,
à
the
Gao,
duration,
4822
1,500,
à Tombouctou, au total
400, 822 for short
13389
acting
répartis entre les
uh,
condoms, les
elements
contraceptifs oraux combinés, les
distributed
contraceptifs oraux
between
progestatifs.
the
Cela a pu être
condoms,
possible grâce
combined
à la
oral
localisation, comme
contraceptives.
vous le savez, avec la
That's what was,
restriction. On ne pouvait pas
we were
interagir
able to do
directement
thanks to the
avec le ministère
collaboration.
dans le cadre de la
We couldn't
planification
act
familiale.
directly with the
L'aubaine et
ministry in family
l'opportunité pour nous
planning.
avait été la
So
collaboration
this was a
qu'on a
great
entretenue dans le
opportunity
cadre
with the
des
collaboration, with the help of
partenariats avec
local
les ONG
partners
locales qui ont facilité l'acheminement des
and
produits
local
contraceptifs à
NGOs,
certaines
which
zones,
helped
ce
us
qui était un grand atout pour
to
nous
supply
dans un
these
contexte majeulement
contraceptive
d'insécurité où l'approche
products
locale et communautaire
in a
est
very
importante,
fragile and
notamment
highly
pour assurer la
insecure
disponibilité
context. It
au
was
dernier kilomètre.
this was important to
Next slide.
guarantee availability in the last mile. Next slide.
Sur
All right, some
la page à
trends,
gauche,
some trend
ça,
to,
c'est l'analyse
on the
situationnelle
left.
qui a été faite.
That's the
On voit que le taux de
situational
rapportage était de
analysis, and we
56%
see
au
that the
1er et 2
rate,
semestre
56%
2023 et 40%
from
au
the
troisième
first to the
trimestre.
second quarter of
À droite,
2023
nous avons la
and
figure qui illustre
30%
les actions
in
effectuées
the
au terme
in the from July to September. To Mir implemented coordination committees regionally and to thanks to these efforts, we were able to improve the rate of report the reporting rate in the orange line with the district from January to September improved considerably. Quite an increase in the period right after the district implemented these new practices. Next slide. And at the same time, to improve the rates, these are efforts to improve the rates in Gao. The rate was considerably increased as well, or improved as well, thanks to these efforts. No, go back to the previous one. Go back to the previous. Yes, this one. Thank you. Okay, from October 2023, you can see we start to feel the effects of the efforts of the Regional Coordination Committee that encompasses all the health districts of the Gao region. This made the rate go from 49 during the first intervention of the Regional Coordination Committee, went all the way up to increased significantly and constantly up to 88% in the second quarter, which shows us the importance of these coordination committees, which were implemented by recommendations of the MIR projects. Next slide. Okay. Good, thank you, Sarah. So this graph, again, the trending on the left, focus on the left, that's the situational analysis right after the intervention. And the data we can see and show Timbuktu region data. Right after the reporting rate was only 28%. With the MIR's intervention, with the combination of all these efforts, we were able to see a considerable improvement. Thanks. There was a slight going back a little. They dipped a little, went backwards a little bit, and then it started to pick up pace in the second quarter, 17% to 32%. We can see that the Timbuktu went from 32 to 71%. This progress or this advancement continues up to the second, it goes all the way to the second semester of 2024. This is explained because we were able to have some of the dips relate to the conflict, to the worsening of the conflict, and with MIR's support, we were able to continue the positive evolution. As you can see, the second quarter 2024 was a little low compared to the first quarter. This is explained because of operational issues and security issues. We couldn't make the second coordination meeting during the second quarter. So compared to the regional trend is a little slower because of the lack of the meeting. This is again another proof of the importance of these regional committees. Next slide, please. Very well, the takeaways. So after the different interventions and results, these are some of the takeaways from our context in Mali, especially the collaboration between partners and allies. We understood that collaboration between MIR and the Global Fund through UMRSS helped us to be able to close the gap and improve feasibility and sustainability of the supply chain. Also, the importance of the role of the community, because they're the first beneficiaries of any activities and intervention. And they are the center of gravity of our interventions. So it's important to instill mechanisms implying the federation of health of community health associations, allowing to improve LMIS data at a district level, increasing the spirit of a competition, improving the data. And the last but not least, availability of contraceptive products in the last mile was possible in the context of law 7008 by MERS capacity building support for local NGOs and logistics management and their strong involvement to improve availability of contraceptive products. Thank you very much. That's all I had for you. Thank you. Back to you.
Thank you, Hamza. Thank you very much. His presentation shows you that coordination is really important between organizations, and that having skilled health workers, giving health workers supply chain skills is really essential, but then also including indicators, specific supply chain indicators, and collecting that data is really helpful to track progress. And we'll be saving questions to the end to make sure all of the presenters have time to get through their presentations. So please hold your questions or put them in the chat in the meantime. So now I have the pleasure of introducing Dr. Rakia Boubacar. She's a supply chain advisor in Niger and is a state certified pharmacist and specialist in blood transfusion and public health. She joined MIHR in February 2022. From 2015 to 2022, she was responsible for the environmental poliovirus surveillance laboratory. And from 2012 to 2015, she was the head of pharmacy services at the Regional Directorate of Public Health in Zinder, responsible for the distribution of medicines in the region and training district agents on the logistics management information system. Thank you, Rakia. It's all yours.
Thank you, Marie. Bonjour à tous.
Good morning, everybody. Good morning, everybody. I'm going to present in French, so I will use the translation. I hope that the interpreters can keep pace of my French. I usually speak a little fast. So good morning, everybody. I have the honor of presenting the big challenge of the big challenges in the last mile, the big challenges of the supply chain. We saw that there is frequent stockouts of essential medication in health centers. Also, the information centers were very deficiently managed, the information system. Also, lack of transportation infrastructure to bring medication to health centers. And lastly, there was insufficient coverage of all the health structures that are supported by MIR, and lack of capacities, lack of training, lack of training, lack of tools, and lack of monitoring and follow-up, sometimes exacerbated by the conflict. Next slide. Diapo. Next slide, please.
Diapo, s'il vous plaît.
Good. All right. Some of the interventions. Very good. We have, when we begin the different interventions of MIR, we had two key points of focus. First, reinforcing the information system in logistics management, the so-called SIGL, it's a French acronym, Système d'Information, and the improving strategies in the last mile. Next slide. Next slide. All
Notre
right.
première intervention
So the
en
first
2022 est le
intervention
renforcement du
in
système d'information en
2022
gestion
was to
logistique
strengthen the
pour
information
comprendre
system
qu'est-ce qui se passe
and
au
logistics
niveau
management, to be
des
able
centres de
to
santé.
understand
Nous avons
what
réalisé une
happened in
analyse
truly
de
happened
la
in health
situation
centers. We
dans
did a thorough and a
les quatre
situational
CSI. À ce
analysis
moment, c'était
in
les
the
CSI
four
d'Adosso et des CSI
intervention
d'Akala.
zones.
Deux
At that
districts sanitaires à
moment,
Dosso et
we
deux
began with
districts sanitaires
two in Dozo and
à Awa.
two in
Et sur
the
la
health
figure de
district of
droite,
Akala.
nous avons les
In the
résultats
right,
de
on the
l'analyse.
left hand, on
Donc,
the
nous avons
right-hand
connu
side, we see the result of
uniquement
the
33
analysis of
ouvriers
the
pour 100
situational
personnels
analysis. The
formés en centre et la
33.8%,
disponibilité
only
des équipes de gestion
33%
est de
properly
181%.
trained
Et
personnel.
les données correctes
Lack of
sur le
tools,
fond
only
de stock
50%
est
of tools
de
available. And the
55,8%.
right
Et
evaluation data,
le rapport de
55.8.
consommation bon de commande et de livraison
Reporting on
correctement rempli est de
consumption and reporting
42%.
on deliveries
Les
with proper
conditions de
documentation,
stockage
only
sont de
42%. So we see generally
70,6%
we
et
have
la
data
gestion de stock de
issues
la
and
fiche de stock par rapport
60% proper
aux inventaires
storage
physiques est seulement
conditions
de
and 52%
52%.
managing the physical
Donc, c'est ce
stocks,
qui
only
nous a
52%.
motivés à faire une
So in a
formation de
snapshot,
274 agents de
this
santé
motivated us
dans les
to
zones
train
d'intervention. Il
more than
s'agit de
200
l'année 2023
more than
et
200 health agents. We're talking about
de 6
2023
districts
back
sanitaires
then,
parce que entre l'année
in
1 et
6 health
l'année 2, nous
districts.
sommes
So we
passés de 4
focused on
districts à 6
training
districts.
between the first and
Donc,
second year. We went
après,
from
nous
4
avons fait
districts
une
to 6
conduite de
districts.
supervision
Then
post-formation
we started to
dans 45
deploy
centres de santé.
further
Pour le moment,
supervision
et nous
of
continuons
training
cette
covering
supervision
47 health centers, and we
jusqu'à
continue
couvrir la
doing this
totalité des centres
currently.
de
We
santé
continue doing this supervision until we covered
d'intervention.
all the health
Donc,
centers
nous avons fait un
of the
constat qui était un
intervention
constat
zones.
important.
We were
Avons
able
amélioré la
to
disponibilité
correct,
des outils de
validate,
gestion.
we
Nous
improved
avons
the
amélioré
availability
le
of
remplissage
management
des outils
tools.
et nous avons surtout
We also
amélioré le
improved the
calcul de qualité
filling
des produits
of the
appropriés,
forms and
ce
improving
qui permet de
calculations,
réduire les ruptures
calculations
quand les
for
médicaments arrivent au
replenishment
niveau des
and
centres de
reorder,
santé.
more smarter reordering, and to improve supply of medications to different health centers.
Slide.
Next slide, Sarah, please.
Diapo, s'il vous
Next
plaît.
slide.
Diapo. Slide. Au niveau de la stratégie, la deuxième
So
stratégie,
in
qui est la
the
stratégie
about the
de
second
livraison des
strategy, which was
médicaments
the
au dernier kilomètre, nous
implementation
avons également planifié une enquête
of
sur les
delivery
points
of
d'étranglement
medications in the
au
last mile, we
niveau
did an
CSI et au
investigation on
niveau
the
des relais
different
communautaires.
bottlenecks
Ces
in
relais
the very
communautaires
last
apportent
mile.
un
The
apport
community
très important
relays
sur la prise en
are
charge
very
du
important in
paludisme
this
simple,
respect
de la pneumonie
for the
simple
care and
et
protection
de
of
la diarrhée
simple
simple.
pneumonia, for
Donc, dans ce
example,
cas, nous avons
and
réalisé
simple
cette enquête
diarrhea.
qui a
We
donné
were able
des
to
résultats
do
superbes et au
an
niveau de
analysis and
46%
with
des
interesting
intervenants
results.
ont dit que c'est
46%,
le
take
manque
a
de
look at
transport
the
qui
distribution
constitue la
graph.
le principal bourreau
46%
d'étranglement,
simply lacked
suivi
transportation. Uh, and they lack
la disponibilité
resources
des produits,
to
parce que
transport.
parfois la
Right
disponibilité
after
même des
the next
produits n'est pas au
biggest
niveau des ports
issue
et de
is
nos outils
availability of
approvissionnants,
products. So
c'est-à-dire du
first,
district vers le
transportation.
CSI
Second,
et du CSI
availability
vers
of
les relais
products.
communautaires.
Of
Et
these
enfin, le retard de
lack of
livraison.
funding or
Maintenant,
resources, then
pour cela,
transportation, and then
pour corriger
availability, and
cela, nous
finally
avons élaboré
delay
un
in
document
delivery.
sur
To
la
correct
stratégie de
this, we
livraison des
created
médicaments au dernier
a
kilomètre
document to improve
en
the strategy for
collaboration
delivery of
avec les acteurs
medications in the
clés.
last mile
Il
in
s'agit de la
collaboration
direction de la
with
pharmacie, des
key
laboratoires de santé
partners,
et de la médecine traditionnelle
the health
avec
lab,
PSM, le
and
Global
also
Health
with the help
Foundation
of
et
traditional
surtout celui qui s'occupe de l'approvisionnement des
medicine.
contraceptifs. Pour mettre en exergue l'adhésion des communes, nous avons organisé
We
et
were
nous
able to
informons avec
we
trois
had
communes
big support of
d'intervention. Il
authorities, and
s'agit
we
de la commune
gathered
de
with
Toumega et de
3
Tingui dans la
intervention
région de Dosso
villages
et la commune de Bambaye dans
in
la
the
région
region of
de
Doso
Tawa. Et
uh,
cela a
and in
amené un
Tawa.
fort constat d'adhésion des communes des autorités
We
communales à la
realized that there
stratégie
was
et ils ont toutes les trois communes ont
community
signé des engagements pour
authorities
faire la livraison jusqu'au
signed, the
niveau du
3
relais communautaire, soit
communities
à
signed
travers le
commitments
secteur
to
privé de
improve
transport
deliveries
et
thanks to private sector support and transportation or vehicles, and also with motorcycles that can help provide this and deliver these medications to different community relays. Next slide, please.
Slide, s'il vous plaît.
All right, takeaways.
Dans ce cas, nous
Some of the
avons,
lessons
par rapport à ces
learned
deux stratégies, nous avons
about these
téléconseil.
strategies, we
Il y a un
have
système rigoureux de la gestion des
different
chaînes
lessons
d'approvisionnement et un
learned.
suivi
First, we have
post-achat
a
qui sont
rigorous, we
nécessaires
need a
pour une meilleure
rigorous
gestion
system of
et un
supply
meilleur
chain
apprentissage des
for
outils. Nous
constant
avons aussi
follow-up to
l'implication des
improve
acteurs économiques
management
dans tout le
and to
processus
improve
pour suivre un
replenishment
engouement et une
and,
meilleure
feeling
appropriation
of the
de la
tools,
stratégie
and
pour la
implying and involving
disponibilisation des médicaments au dernier
local
kilomètre.
community
Et pour
actors in the
cette dernière
process to improve
implication, le
availability in the
processus
last mile. For
continue
this
encore
lot,
sur le
to
terrain
imply and
avec le
engage
suivi des
the
structures
locals, it's
et
still
au niveau
ongoing
des relais communautaires et au niveau des
to
CSI
improve the
pour qu'ils puissent,
process
après la mise en place
with
de
the
la stratégie,
community relay, so
selon
that
cette
after the
disponibilité des unités
implementation of the
et jusqu'au niveau des
strategy,
relais et aussi au niveau
to
des CSI
maintain
et des
and to give
approvisionnements.
continuity of availability for those locals in
Diapo,
charge
s'il
of
vous plaît.
providing these medications. Next slide, please.
Slide. Diapo, s'il vous plaît. Slide. Donc, j'arrive à la fin de
Very
ma
well.
présentation.
So this is the end of my presentation. What are the conclusions? We know that mastery of the information system is key for success and quality, together with the implementation of long-term mechanisms for delivery. This is important to improve health of the population. We expect to have continuity of mobilization of the local community actors and local actors and imply them in research and the search for durable lasting mechanisms to improve last mile performance. Thank you very much. Back to you, Sam.
Merci
Thank you.
beaucoup.
Thank you
Je
very
suis à la
much.
fin de ma
Thank you very
présentation.
much.
Thank you.
I'm here for questions. This is the end of my
Thank you very
presentation.
much.
Thank you very much.
I'm in the end of my
Thank you
presentation.
very much.
Thank you, Rakia.
Thank you very much.
Yes, so another, I guess, some takeaways that, training staff in LMIS is really, really important to get that logistics data, and involving and being in really strong coordination with municipal actors is also very key to make progress, as is having a last mile strategy, delivery strategies is also helpful to make sure commodities reach the last mile. So our last presenter, last but not least, I'd like to introduce Dr. Mohammed Abdalgadir. He is the chief of party for MIHR in Sudan and has more than 16 years experience working with international NGOs in humanitarian and limited resource settings in Nigeria, Somalia, Northeast Syria, Northwest Syria, Yemen, Papua New Guinea, Sierra Leone, and Sudan. He's worked in various capacities as a medical coordinator, health and nutrition coordinator, TB specialist, and health researcher. And he's worked closely with supply chain systems for health supplies at different levels, from the health facility and end user levels to support international procurement to ensure procurements of health supplies are aligned with national policies and systems. And he has a master's in tropical medicines from Nagasaki University in Japan. Mohammed, the floor is yours. Thank you.
Thank you, Mary. Hello, everyone. I'm Mohammed Abdalgadir. I'm going to present to you Sudan experience in supply chain given the current situation. So I will start with the challenges.
You can keep your camera on. You can keep your camera on.
I think, okay. So I'm going to explain to you the challenge that Sudan experience, that actually the challenge of the supply chain system in Sudan actually has been existing since during the last few years, and has been exacerbated recently by the ongoing conflict in Sudan that has recently severely impacted the current the transportation of the supplies. Here I can explain that currently the situation, because of the territorial control and or the geography of the control of those warring parties, so that deeply impacted the distribution system from the national level warehouses to the end user at the health facility level. And that has been affected by insecurities in the way from the national or the warehouses at the national level or at the intermediate warehouses that either by the Minister of Health or humanitarian actors, and WHO is leading for health and other like UNICEF and leading for WASH, that has been deeply affected. The road, most of the road have been inaccessible for the supplies. Besides that, there is increased bureaucratic and administrative impediments that has been enforced by the warring parties. Also, the only solution that the people there they will seek about is the cross-border from Chad and from South Sudan. For us, as we are supporting South Kordofan state, the solution for IMH outreach with the supplies for MSH and WASH, that was through South Sudan, but unfortunately, the approved cross-border that has to go also, it will make challenges to reach to South Kordofan. Next slide, please. Next slide, please.
Next slide.
So intervention and activities, like as IMHI is participating in different coordination forum at the national and state level, that helps to improve the supply chain at the IMHI supported areas, and also through the bilateral coordination with key humanitarian actors like Alima, like Save the Children, and others at the operation areas, and with WHO zonal office in South Sudan that improved the MSH and WASH supplies in IMSHA support site. Close coordination collaboration with the IMSHA partners. For example, the Midwife Association has helped to improve the access to essential supplies, MSH supplies, including the iron and folic acid supplement to the pregnant woman at the local communities through donation from WHO. That also help us to reach to the end user at the community level. And also the circuit rider teams, the community managed team to repair and to fix the water yards. Also in collaboration with UNICEF and NRC, were able to donate it or to access to spare parts that were not able to send to South Kordofan. Internally, we are able to, the circuit riders to fix and to repair like around 32 water yards, and that has helped. Here, the key message is that the collaboration among the UN agencies, humanitarian actors, that will help to utilize available resources at the state level and bring it down to the community level. Working with MSS and WASH partners to improve the management of supplies at the facility level through the building the capacity of the MSS provider or the health providers in improving the rational use of medicines or improving the dispensing skills, and also improving the tracking and monitoring of MSH and WASH supplies at the facility level. Conducting also state level supply chain workshop with health and logistic cluster to identify key driven of the stock out at the state level, and also to identify solution how to improve the stock availability and existing resources. Next slide, please. Here, this map is like showing, like this slide is WHO showing the WHO country office showing the warehouses mapping, and that is important for us as we are reprogramming and shifting some of the MHR activities to Eastern Sudan. Also for us to have like close collaboration with the WHO as the lead agency, as the lead UN agency for health, supporting the humanitarian health supplies. And that's very important for us to understand the supply chain system for WHO, just to help the local communities where MHR is supporting MSH and WASH. Here we can see from the main port, the main warehouses in Port Sudan, and from there is like a Kosti warehouse that is temporary, and also there is before there was in Wad Madani warehouse. This it's like can serve like national warehouses that can distribute for the whole country. For us, when we plan accordingly to the existing humanitarian supplies in country that is like collectively aiming to improve the MSH supply chain at the lower level. Next slide, please. And here maybe in the previous slide, maybe I hope that our colleagues from WHO, Claudia, Dr. Nader, if they are in they can maybe give more insight about the level of the supply chain at the WHO country office, how to improve and support the overall humanitarian supply chain in country. Here, the result that improve access to health commodities through the distribution of MSH supplies with support from the South Kordofan Midwife Association to reach to local communities, through community midwives. Also established a collaborative agreement with UN Peacekeeping Mission in Kaduli, that is UNISFA. Actually, it's the only operating flights now from South Sudan to South Kordofan. Successfully, we managed to establish like agreement, collaborative agreement with ASCARE International and MHR with UNISFA, and that helped us to facilitate the travel of some of MHR team who attended training in Kampala to travel back to South Kordofan. And we see this is like a breakthrough that we are able to access South Kordofan, especially these days, through South Sudan using the air flight UN flying flight. So here support MHR supplies chain with South Kordofan to support WASH supplies to Kadugli office. Also through close collaboration with WHO South Kordofan office, we managed to reach to the local communities with supplies, especially the South Kordofan is semi-besieged, especially Kadugli is semi-besieged. There is minimum items reaching to Kadugli. Identifying also new routes, as I mentioned, through South Sudan, that air so far is for passengers, but we are hoping that, and we are looking forward to see that can be used for shipment of MSH or WASH supplies. Next slide, please. So here we are showing the trends analysis of outpatient consultation from the 23 January, actually 23 until June. Yeah, it's like 1 year. Here is till June 2024. Here we can see that we analyze the MSH data and the outpatient consultation in MHR supported facilities, and triangulated with the using the shock log tools to analyze against the shocks and stresses, and to see the impact of these stresses on the accessing and also availability of the service. And when we also, if you can see the ones in red that represent the shock, where we like mark with arrow, and the green is showing the adaptation. And the time that we start like providing financial and operational support to the 10 health facilities, start the improving little the or preventing little the deterioration in the access to the surface, and that also including distribution some of the supplies to the supported facilities. So this here is can show, maybe it can be expanded more to express, to add more elements for analysis for supply chain. But for now, it's just showing that how this shock and stress is affecting the accessibility to the health facility and also the service delivery in these sites. Next slide, please. Similar analysis is for antenatal care visit number 1 and also antenatal care visit number 4. The comparison also against the shock and adaptation, we see that like sharp decline in service that happened in December 2023 when the conflict escalated in the 3 localities in Dalan, Habil, and Karugli. And after then, with the support also to the community service, MSH and WASH slightly improved. But we see the deterioration of the service delivery and also that including supply chain with the ongoing conflict. And there is various, including the disease outbreak and also the blockage of the internet and mobile services. Next slide, please. The lesson learned from our experience supporting the supply chain of MSH and WASH, like the close coordination with key humanitarian actors that work for health and WASH will help improve the supply chain system at the lower level. Leveraging additional key humanitarian actors like outside of BHA and WHO and IMHA, who already supporting additional transportation of the supplies from the main warehouses to the community level. The effective coordination among the humanitarian actors and UN agencies will help increase the efficiency and effectiveness of the humanitarian supply system. So all from my side, and welcome for any question. Thank you.
Great, thank you, Mohammed. I think we are now going on into questions. So I think Nadia is also going to help me with Q&A. Nadia, have you, let me see, there's been a lot of questions coming through.
Are you going to do the summary first though? And then we'll do the Q&A?
Mohammed?
Oh, no, I thought that was overall, was it not?
Oh, yeah. Yes, so just very quickly, the summary, we just wanted to provide a very quick summary of the panelists and our findings. So one of among many findings is that just having the need for trained staff with supply chain is very, very important. Having recurring training annually or through on-the-job trainings is very essential to ensure that forecasting skills are strong, so that there is availability and that there is logistics data, and that in conflict areas this is even more essential. And in most countries, having standard operating procedures is important, and keeping those up to date, so that health workers are all following standard logistics management practices. And in terms of just delivery to the last mile, especially in fragile settings, transportation and getting working closely with UN agencies, humanitarian actors, and NGOs and partners is very essential. And partnering along with local governments as well and health staff to help coordinate and develop solutions is a key factor, as well as that will also help create ownership, and also developing last mile strategies with those partners, and maximizing attention to commodity security is another key factor to improve and strengthen commodity availability. Having staff appointing specific staff to monitor the supply chain, to monitor stock levels, and making sure that community health workers can also facilitate access to short-acting methods by dispensing them when they can in more harder to reach areas. And then also giving them the skills to be able to refer clients, and using midwives as well, who can provide a limited number of commodities, but also expanding the availability and access to reproductive health and MNCH products is important, especially in the hard to reach areas and during in fragile settings. So I just wanted to quickly then turn it over to Nadia so that we can get a few questions in before the end of this session. So Nadia?
Yes, so I'll start with the big macro question that Kevin Pills asked, and then we can go into the more detailed questions. But his question was, what's different about supply chain in these fragile / humanitarian settings? And he observed that it seems like it's similar. The recommendations are similar to what you see in another country with a similar maturity level. And yes, I think that ultimately the supply chain principles and the solutions are the same. They do not change. We've been working increasingly with humanitarian partners over the last several years with funding from BHA, and we've gone pretty deep into exploring what's different. And the principles, the supply chain principles are the same. The recommendations are very similar. What's different is the context and the actors that you're operating with and all of the elements that you need to include. And also you're working within a very changing dynamic system. So the difference is that, for example, you have, when we talk about an ad hoc system in a stable environment, in a humanitarian or fragile setting, the ad hoc system means that you have many, many, many more actors bringing product into the country, sometimes not coordinated with one another. And also you have a whole humanitarian channel that's operating sometimes completely independently of the government, who are also operating their own supply chains and collecting their own data. And that data doesn't necessarily all flow into one system. And the decisions that are made about that data are often happening at lower levels of the system. So that was part of the reason for a focus on the last mile on MIHR, because a lot of those decisions are being made at the lower level or from a bottom up perspective. And also because you might have conflict, it may be only certain districts with whom you can even work at all. You're not working at the national level at all. You also are kind of cobbling together data about populations that are moving, refugee populations, internally displaced people. So whatever you forecast may change dramatically from 1 month to the next, or 1 week to the next, or 1 day to the next. So you have to be constantly updating your assumptions and using all kind of creative data to forecast who's coming. And the art of forecasting becomes even more artistic in an environment like that. And also the facilities themselves are moving. The warehouses themselves are moving. They're also temporary warehouses, temporary facilities. So the system you may have mapped a year ago is no longer the same system. And also the demographics is no longer the same demographics. Even the disease burden is no longer the same disease burden. So you have to constantly be updating all of your assumptions, even about the medications that you need. And then sometimes medications come in that you didn't even have on your essential medicine list, which happens even in stable countries, but the risk of that is even more in fragile settings. And sometimes those products are not adequate to the population. Even strains that of medicine, certain types of regimens for which the population has a resistance, and so could lead to, more infection. So these are just some top line things. There's many more, but I hope that starts to answer the question. There was a question about reporting rates. the question was, and maybe the team can add, what causes reporting rates to be low? Is it just lack of data? And no, I don't think it's only lack of data. I think reporting rates are low if the people in the lower level of the system are don't feel trust that reporting will result in any benefit to their facility. Maybe they're not getting feedback. Maybe they're not getting the product they need. So why report? They don't feel like they're part of something. Maybe they don't understand how to fill out the form. Maybe there's lower levels of literacy. Maybe they're too busy, because a lot of the time, just like in stable but very fragile settings, there's staff that are overburdened because they're actually the service providers, but they're expected to fill out the form. So I don't know if Hamza or Rakia or Mohammed want to add anything on reporting rates.
Yeah, thank you, Nadia. Just I will start before my colleagues, Dr. Hamza and Dr. Rakia. In our case, we experienced displacement, almost 3 health facilities or 3 locations, entire population, including the health staff and the population have been displaced. So no one there. It's for sometimes, so that affected the service delivery and reporting as well. But
Great.
hopefully, and successfully, were able to resume while they move to a new location. They continue the health staff where they are in the holding center in another place. They start providing the health services, and that is unique. I hope that maybe we are able to capture that, how they, when they're displaced, how they carry with them the supplies, and also how they keep providing the health service while they are displaced. And I think that's unprecedented. Yep.
Sorry, go ahead. We're running out of
Yeah,
time.
that's all. Thank you, Nadia. Yep.
I'm so sorry, we're running out of time, but I think this warrants a follow-up conversation. So all of you who are interested in having a follow-up discussion, just email me and we'll set up a follow-up Zoom call to really get into the discussion more, because I think we had to have the presentation even to analyze some of this. So anyone interested in a follow-up, just write me today and we'll set up a follow-up Zoom to have a discussion, because we're out of time today. But thank you very much. I think, Chris, you were going to say something to close out. And these are the resources. We put the links in the chat, and we can follow up with me as well to get those documents.
Sure, thanks, Nadia. Yeah, I can just make a quick comment just to let everyone know we did record today's session. Within the next week or so, it will get posted to the Momentum website, so you can find it there. We'll post the recording and the slides there for your reference, and if you want to share it with any of your colleagues, who were not able to join today. So yeah, thanks everybody for joining, and thanks to Nadia, Maria, all of our presenters and organizers who made this webinar a great success. So thanks, everyone.
Thank you. Thanks, Rakia, Hamza, Mohammed.
Thank you, Nadia, and thank you all.
Bye-bye, everybody. Bye-bye, Nadia, Marie,
Bye.
Sarah.
Thank you.
We'll be sending the recordings